Hello, today we're going to talk about some neurological disorders, and specifically, we will be looking at seizures and strokes. So, when we talk about seizures, it basically is defined as a sudden or brief disruption of the normal functioning of the neurons in the brain. So, essentially, we have neurons that are communicating information both in between both hemispheres of our brain as well as with the rest of the body of our body. And whenever there's a disruption of that communication, that's what we call a seizure. So, what does a seizure look like? Well, you can have basically like a sudden cry or fall that's followed by convulsive movements of all of the limbs. So, they start just convulsing and contracting all of the muscles within their body. We have shadowed or shallow or uninterrupted breathing. And so we can actually see cyanosis, that blue coloring of the skin that starts to happen because we're getting a lack of oxygen because our breathing uh, is interrupted because of what's going on within the brain, and that disruption of the electrical flow that is stimulating us to breathe is interrupted. We can also get a loss of bowel or bladder control. So they might be urinating on themselves or defecating on themselves. When you look at it, we are contracting all of the muscles in our body, and that can take a toll on the digestive system too. And that's when we can actually see feces come out or urine come out. When they are done with the seizing, it is a very slow return to consciousness. So this is kind of our post-ictal phase or our post-seizure phase, in which there's confusion, there's fatigue. Their body actually just went through a an immense amount of energy with those contractions. And so it does wear the body out. It can feel like you just exercised really hard and just feel really fatigued as your brain is starting to become accustomed to having oxygen in it again, and that the neurons are no longer disrupted. That just takes a while for everything to get going. So there's confusion that's setting in until it's been, a period of time after the recovery of the seizure. Now, everything that I just described to you right now is basically what we see in a generalized tonic or clonic seizure, or also known as what's called a grand mal seizure. That's French for big bad seizure. There are other types of seizures, and a lot of people don't realize this. So sometimes, instead of having that just complete contraction, fall down onto the ground, incontinence, and such, instead, what we can get is like blank staring or chewing with their mouth, where it's like they're not actually chewing food, but they're just chewing like on their cheeks and their tongue within their mouth, or other repetitive, purposeless movements. So it's just repeating movements over and over again that have no purpose. They might be wandering, have a lot of confusion. They might be trying to speak, but you're not able to understand what they're saying. They could be crying, screaming, running, flailing their bodies around, right? A sudden loss of muscle tone and then just fall. So instead of complete contraction, they just kind of lose their muscle tone and collapse down onto the ground. Or they can even be exhibiting things like picking at their clothes, scratching at themselves, taking their clothes off, just kind of like restless kind of environment. And it's hard to be able to communicate with them, and they're not really paying attention to anyone else around them. They're kind of like within their own little world. And this, instead of being like the grand mal seizure where all the contractions were happening and the collapse down onto the ground and losing all control of the body with contractions and such, this is actually known as what's called a partial seizure, or a complex partial seizure. So, what causes seizures within the system? Well, in infants, high fevers can cause seizures. It can happen in adults as well. I would say that it's a lot more prone to happening in infants when we're just unable to control the temperature the way that we would like to. If somebody is using drugs, or having a withdrawal from alcohol, you can exhibit seizures as well. If there's a near drowning situation, or for whatever reason, there's another lack of oxygen that's getting to the brain itself, it can cause a seizure. There can be metabolic disturbances. Something like diabetes would be an excellent example of that. If there was direct trauma to the head itself, it can start to build up pressure within the brain, and we can actually lead to seizures as well. If there's some kind of a tumor, an infection, or a stroke that's occurring within the brain, there's a lack of blood flow getting to things, in which it can actually cause signs and symptoms of the seizure as well. And also complications of things like diabetes or pregnancy can cause seizures. Now, in the medical world, we always like to use acronyms. And so some of the acronyms that we use as far as seizures go, or what caused the brain to stop, quote unquote, would be things like toxins. So the two is TO for toxins. So if we've got drugs on board or other types of toxins that are coming into the system, it can disrupt those brain waves. Sugar, having not enough sugar. So that would be in the case of diabetes. In extreme cases in diabetic ketoacidosis, we could also be having too much sugar within the system causing a seizure. Temperature, either having too high of a temperature or too low of a temperature. So both with hyperthermia and hypothermia, you can have seizures. Oxygen, not having enough oxygen, so hypoxemia. So that can cause a seizure as well. Or if there's too much pressure within the brain. So you have like an intracranial pressure that's starting to build up. So that's an acronym that's using and figuring out what causes the brain to stop. So these are good questions to be able to ask yourself, like, okay, what could my patient be exhibiting right now? What is causing the seizure? Is it that there's toxins in the system? What can I do about that, right? Sugar, how can I find that out? You can take a chemical blood glucose. Temperature, you can take a temperature to see if maybe that's being impacted. Oxygen, we can take a look at the SpO2 and seeing what's happening there, and looking for other signs of brain trauma, or that there might be that buildup of pressure because of an injury, like a basal skull injury or some other kind of injury to the head. Now, this isn't the only one that we use. This is kind of the simplified version. We can also use what's called AEIOU tips, working along the same premise as far as what caused that brain to stop. It's another acronym for it. But this one is getting to a little bit more detail and giving you more ideas of what to look for as far as what might be the issues with this particular patient who is suffering from the seizure. So things like alcohol, and alcohol withdrawals as well could be causing it. Epilepsy, just a condition in which there's disruption throughout the brain that causes repeated seizures. And we'll talk about epilepsy in just a moment. Insulin. So is there too much insulin, not enough insulin, whatever the case is when it comes to diabetes? The O can be for overdose or for oxygen. So it can be other drugs besides just alcohol in which we're overdosing on them. And then also like opiates is a big one that can cause a lot of seizures as well. So that's something for us to consider. And then is it oxygen? Is there not enough oxygen on board and getting up to the brain? Uremia is a condition in which the kidneys are not processing urea very effectively, and it creates a lot of nitrogen within the system. And that can actually lead to seizures as well. So that's the AEIOU. And then TIPS is the T is for trauma or toxins. So maybe it's not drugs, but it could be other types of toxins that are coming into the body, right? There's some kind of a poisoning that's happening, or if it's trauma and we're looking for that intracranial buildup pressure. Infection can actually cause seizures as well. Usually a fever will go with it as well. So you can be looking for signs and symptoms of that temperature and finding out if there's a fever setting in because of infection, either within the brain or other places in the body that's raising the temperature of the body. And the brain doesn't respond well when our brain gets to a higher temperature than what it's used to. Seizures can also be caused by psychiatric emergencies. So just making sure like we're looking for any kind of indication if there's medications that they might have in their pockets, or any kind of a medical alert tag that's alerting us to any of our medical or psychiatric conditions so that we can understand what's going on with our patient. And then stroke as well. And we'll talk about stroke in a lot more detail, but it can lead to seizures as well. So that's our AEIOU tips. So epilepsy. So epilepsy is a seizure disorder. It's a neurological disorder that is chronic. It's not just an acute episode. You can have acute episodes within it as far as when you have a seizure attack itself. However, this is something that it's not just happening to you once, it's repeatedly over time. So you get recurring seizures and they're not invoked by anything. It's just a disruption of the brain stemming from the brain itself. So when you're looking for things like, looking for temperature and oxygen levels, and is there kind of any history of an injury of any sort or a psychiatric emergency or anything like that, you're finding none of these are applicable. It could be that they are an epileptic patient. Usually with epilepsy, they will be wearing some kind of a medical alert tag, either on their wrists or around their necks as a necklace to let you know. And it's a good thing to realize that medical alert tags are taking a new form these days and that they actually become more fashionable. So they can actually be mistaken a lot for jewelry instead of an actual medical alert tag. So if you're finding things around the wrists or around the necks, do take a moment to look at it and see, is this just jewelry or could there be something imprinted on it that lets us know? It's not always just that standard a medical alert tag that has like the little beaded chain that goes around it with that, but typically it does have some kind of a medical symbol on it. So just pay attention and make sure you're looking at that jewelry to find out if there's any leads on what may be happening with your patient. Causes of epilepsy, it could be originally contracted because of a stroke, a brain tumor, having infection within the brain, having some kind of a past head injury, metabolic issues in general, or other neurological conditions. And there is a genetic component to it as well. Approximately over 3 million Americans of all ages do suffer from epilepsy. And as I said, they typically wear a medical alert tag to let us know. With our patients who are epileptic, having strokes or having seizures is not new to them, right? So this is something that is a commonplace for them. They just need to make sure that they're kept safe during the process and not hurting themselves during the seizure and that they recover appropriately. So we're going to go back now to our generalized seizure, the grand mal seizure, in which there's just electrical disruption that's involving the entire brain, not just sections of it. So what are the different stages that we will see? Because it does go through these stages and it goes through them in order. So when you're seeing somebody having a seizure and you are familiar with these different stages, it can let you know, like, where are we at within this process. Seizures will always begin with some kind of an aura. It can be a smell, it can be a taste. They might see things across the vision of their eyes. They might just get it like an overall feeling that something is happening within their body, or they could potentially be hearing something. What it is, it's like a trigger to let you know that a seizure is coming. And everybody who has seizures experiences an aura. If they are used to having seizures, they often know what their aura is because it tends to stay stable across all of your different seizures that are coming from the same issue. So if like it's epilepsy or such. So I have a friend who smells peanut butter, right? That is what she knows when she is smelling peanut butter and there isn't peanut butter around her, that she needs to brace herself because she is going to be heading into a seizure. This is also when we talk about like seizure dogs and assistance dogs, they are trained to be able to recognize when an aura is happening to their human, and that's how they can alert them. So typically you'll start to see the dogs kind of fidget a little bit more. Some are trained to actually come up and put a paw on the human whenever they're sensing that the aura is happening. And so that the human now has a little bit of recognition of like, hey, I've got this alert, I've got this trigger that I know that now the seizure is coming, and the dogs are what's picking up on that. So that's how seizure dogs work, which is actually really amazing. Um, The next phase that we see in grand mal seizures is the tonic phase. And it only lasts about 10 to 15 seconds, but you get complete muscle rigidity. Then you go into the hypertonic phase, and it's this extremely short with only 3 to 5 seconds, in which it's like extreme rigidity. It's like you have tetanus or are being shocked by electricity, and everything contracts up. Then you move into the clonic phase, and this is where we typically think of seizures, right? It's the convulsions. These can last anywhere from a couple of seconds to a few minutes. It can be longer in length. And then after that, we move into that postictal or the post-seizure phase. And this is the recovery time. We are using so much glucose to be able to flood the muscles that were all contracting and the brain cells that were disrupted in order to give them more sugar to kind of repair everything in the process. It's as if we just did a big workout. And so it's like your body cells are starving and they're wanting to bring more glucose in for recovery. So you tend to be really fatigued in this time period. And as you're coming back and getting good oxygen back up to the brain again, they're drowsy and are slowly coming back into reality and being able to pay attention to things. So these are our stages that we will go through in a grand mal seizure. It starts with the aura, it moves into that muscle rigidity in the tonic phase, then it goes extreme rigidity in the hypertonic phase. Then our classic convulsions all happen during that clonic phase. And then during the recovery, it's called our postictal phase. Now, that was our generalized across the whole brain type of seizure. We can also have what's called a partial seizure, as we talked about earlier, in which the electrical disruption is only involving a portion of the brain. So our signs and symptoms, as we talked about with the chewing and the picking of clothes and agitation and, roaming or walking or pacing or doing repetitive movements, it's just localized or focused in one area of the brain. So what does that look like? There's two different versions. We have the simple partial seizure, in which it's causing things like that rhythmic movements, the twitching of the arms, the face, the legs. You just see that twitching that's starting to occur. They can experience things like tingling, weakness, maybe sounds and smells or tastes, maybe upset stomachs or kind of visual distortions that could be happening as well. They might also be exhibiting psychic symptoms in which they get feelings of like deja vu, like this just happened to me again, and something feels weird in this situation. They might even experience hallucinations or extreme feelings of fear or anxiety, where it's almost, confused with like a panic attack, but you're seeing like the twitching of the arms and these sensations come along with it. It's not just the fear and anxiety, but it's other things that are in combination with it. These simple partial seizures usually only last less than a minute. And it could be like a warning sign that a generalized or grand mal seizure is coming on its way. So it might be something where, it's just kind of giving you that indication that there is more left to come. So that's our simple partial seizure. We also have complex partial seizures. And these are having, it's just more involved, in which they have a lower altered a level of awareness, right? There's more confusion or complete inability to actually even be able to respond at all. They can be experiencing like these automatic, purposeless behaviors, such as like picking up the clothes, chewing, mumbling, twitching, things like that. It can also be followed by emotional outbursts where they start like shouting or yelling. And usually it's incoherent words at what you're going with, but it's just something to realize that that might be happening. And because of all of these things of like this confusion and lower level of awareness or of consciousness and this chewing, mumbling, and emotional outbursts, are often confused with things like being drunk or being high on drugs. Or maybe they're just disruptive and belligerent and aggressive. And so it's really interesting for us to be into a position when we're seeing somebody who's appearing drunk or is appearing like they might be intoxicated or having some kind of a psychiatric issue. we need to start realizing it's not always what it first seems. We've got to be able to recognize that there are other issues that are actual medical issues, right? Besides just being drunk. I mean, yes, being drunk or being intoxicated is a medical issue as well, but sometimes it's even a bigger issue like that, with like head injuries or strokes or seizures or other psychiatric emergencies. So don't just assume somebody's drunk, but we need to actually start monitoring them, trying to have conversations, seeing how in touch with reality they are, and not just chalk it up to being drunk and disorderly and leave them alone. So I've got a video for you to watch that's actually showing a complex partial seizure. A guy is just walking along at the mall, and now we'll take a look and see what happens. So as you can see, there was a lot of twitching, there was a lot of movement. He had been walking normally before, and then all of a sudden drops his bags and starts to like continue to walk, and is shaking and is not communicating very well, right? And so this is something that could be a bizarre scene to be able to see, to witness, but people don't automatically assume that it's a seizure because they only think of seizures as when the person collapses down onto the ground and starts convulsing greatly. And so we just need to watch that there are different types of seizures that we can have. So as far as treatments go, what are we going to do for our treatments? For our grand mal seizure, we need to make sure that the scene is safe. They're doing a lot of convulsing, a lot of muscle contractions. We want to make sure that things are clear around in the area, and then they're not going to bump their head on anything or pull anything down on top of them. If we're not thinking this is due to a trauma, it would be wise for us to place the patient in a recovery position. If you remember from your CPR or first aid classes, recovery position is basically when you're laying the person down on their side, their top leg is crossed over their bottom leg, so they're almost propped up on that top knee. And what that does is it drops the face a little bit towards the ground, but keeps you on the side. And by dropping your face a little bit more towards the ground, it allows for, if there's any vomiting, for vomiting to be able to come out and not block the airway at all, because it's able to just exit through the mouth because the mouth is open towards the ground. It also, our tongue is attached to the jaw. So when the jaw drops forward, it actually can help us to open the airway up if they're not able to control their own airway themselves. There's a lot of rumors that are out there, and you'll see in older medical textbooks on things like making sure you've got a bite stick to put in their mouth so that they don't bite their tongue or anything like that. Do not do that. We never want to take somebody who's in a compromised position and introduce something into their airway that would cause them to start choking or stopping them for breathing. So we're not going to do anything like bite sticks or try to do anything like that. Can they bite their tongue? Yes. And can it cause bleeding? Yes. But it's not like we think of like the rumors used to be they'll bite their tongue off. They're not going to bite their tongue off. There could be some bleeding, but we'll deal with that afterwards when they're recovering. We also don't want to ever hold anybody down when they're convulsing. The force of the contractions that they are going through, if we tried to like pin them to the ground, it could actually break their bones and cause further damage in them. So instead, we just want to protect them from injury. So just making sure there's nothing laying down around them. If we can have like a pillow to put their head on so that if they're hitting their head against the ground, we're not going to hold their head down, but just protect it by putting cushions around them, and then clearing the area just to make sure that there's nothing that's going to cause them further harm. Our biggest job is really just to look at our airway, breathing, and circulation and make sure that it is maintained. So especially after the recovery, we can't do anything while they are really in the process of the convulsions, but we do want to make sure that they have a good airway as they're starting to recover. If there's fluid, blood, vomit, whatever the case is in the mouth, we're going to make sure that we're suctioning that out and keeping them on their side to let it drain out. We can administer oxygen just to help with that recovery time period, and then just monitor their, respiratory and cardiac state. So we're just making sure that we don't need to head into CPR if there was like a total disruption of things within the body. So while it's happening, things that we want to assess for, looking around, was it brought on because of a trauma? Can we tell what happened to this person? Could it be that they were aspirating, like for instance, were they in water at all, if they were swimming or in a hot tub, and could that be causing what the issue is, in which there might be water that's getting into the lungs itself that we're going to need to make sure to suction out as well. Looking at our patients, are they elderly? Are they pregnant? Could they be diabetic? Looking for those medical alert tags as they're starting to come back around in their consciousness. It would be a good idea for us to check those blood glucose levels, because that's something we can easily do, even while they're still returning to consciousness again, and find out if maybe it was due to not having enough sugar or having too much sugar within the system. And then we also want to see how long the seizure lasts and how many seizures they have been having. If this is the first seizure of the moment or if this is a repeated seizure. Seizures that are it's called status epilepticus, in which we have a seizure that's lasting for more than 5 minutes. So when we're talking about that whole aura to when we're just coming into that postictal phase, if they were convulsing for longer than 5 minutes, they have had severe disruption of oxygen to the brain. And so that is a mandatory transport, and it's called status epilepticus, as well as if it's seizure that was then followed immediately by another seizure. So before they come into that postictal phase and they're starting to recover, and if they go right back into a seizure again, that is also cause for mandatory transportation to the hospital. There's just too much disruption of oxygen getting up to the brain that it can cause long-lasting, and we also need to a long-lasting detriment to the brain. And we also just need to find out what is going on that it's causing this much of a seizure to happen, because seizures don't typically last more than 5 minutes, and they don't typically repeat right away. So whenever we're dealing with traumatic injuries or aspirations, or we've got some extreme patients like elderly, pregnant, diabetic patients, or seizures that are lasting more than 5 minutes or occurring within a series, this is when we need to activate advanced life support to get paramedic partners on their way, and we need to rapidly transport to some kind of a hospital, because those are the kind of the red flags we're looking for when it comes to seizures. After the seizures, continue to monitor that cardiorespiratory status, monitoring for the airway, breathing, and circulation. Evaluate them for any injuries, to see if any injuries were set in because of the seizure itself or because of trauma before the seizure. Assess for that return of consciousness and reorientation. We want to make sure that they're still continuing to come back into alertness again. If they have an emergency contact information that you can find within their pockets or on their medical alert tag, we could alert them, especially if it's somebody who's like having who's suffering from epilepsy or has frequent seizures. They often will have an emergency contact listed on their medical alert tag. And then again, activate the advanced life support or transport them to the hospital if consciousness is not returning, or if the confusion is persisting for more than 20 minutes. So if that post-ictal phase is lasting for more than 20 minutes, that's a sign that something bigger happened, and we need to make sure that we're getting them to the hospital as well. So if there's witnesses around, it's good for us to be able to get information from the witnesses, because the person who is coming back from that post-ictal phase isn't always able to remember everything that's happening, especially as they're still in those beginning cases or the beginning stages of recovery. So ask people around the description of the seizure event, identifying information, like, is it somebody that they know? Do they know anybody that they could call? Do they have any information about the patient that they have a condition that might lead to the seizure? Just trying to get some information from the people who are around. Do they have a prior history of seizures or any other medical problems? Just to kind of start understanding what's happening with the seizure. So that was all for our grand mal seizures. So now let's just talk about our partial seizures that we have, like the complex partial seizure of the video that we were watching with the guy. Remember that it can be reported as drunkenness or illegal drug use, or it can be misdiagnosed as another medical condition, such as like a stroke or a diabetic reaction. Or sometimes it's just like a dispatch call for somebody who's acting really strange, right? They can't pinpoint what's going on. They just know that something isn't right. The person's walking around. They don't know if there's something going on with them or if they're just drunk and disorderly, right? That might be what the call is coming through on. So when we're trying to like deal with patients that you're getting for like people are just looking strange, or it might be drunkenness or disorderly disorderly conduct, sorry. Start thinking of things like, okay, what else could this be? And keep these things in mind. And, in the medical field, we always talk about ruling out. What is our worst case ruling out of things? If somebody has abdominal pain, let's say, right, and you're trying to think, what's the worst thing this person that could happen to them? Well, when we talk about if it's a female, the worst thing would be like an ectopic pregnancy, right? If it's not an ectopic pregnancy, or if it's a male, then our next worst thing would be like kidney infection, kidney stones, probably I would actually go more for appendicitis, because that has a lot more risk involved in it. But these are the things you're trying to rule out and say, okay, what questions can I ask to rule this issue out, right? Breathing issues, you're going to start with things like allergic reaction, because that's something we can fix really quickly if we have the ability to do that. Or is it, asthma attack? Is it you're starting to like say, okay, what can I ask? Is this person allergic to anything? Do they have a history of asthma? What is causing this breathing issue? When we're talking about somebody who's acting drunk and disorderly or strange, confused, right? We're thinking things of like, what questions can I ask, or what measurements can I take, in which I am trying to rule out things like stroke, seizures, diabetes, right? Having hypoglycemia. Like, these are the things that we're starting to rule out. So what questions can you ask? What vital signs can you take? What things can you observe to start leading you down a path, and keep your eyes wide open instead of just making assumptions on things? So you're looking for sudden loss of awareness, automatic, purposeless behaviors, such as like picking at the clothes, the chewing, the mumbling, or kind of just wandering. We saw in that video, the guy was just kind of walking around and was shaking during that process. He didn't really seem to have a purpose in where he was going, and didn't quite know where he was going. When you're dealing with somebody who's having a complex partial seizure, you need to make sure that we're approaching them cautiously. You never know if there's an outbreak that could happen. They could become violent, but it's not a guarantee. So it's just, you're kind of monitoring the situation and just seeing, is it safe for me to be able to speak real calmly, not trying to provoke the person at all, because you can provoke somebody if you kind of appear too challenging to them. It's good for us to kind of contain them where they're at by just having people stand in different areas around them, but don't like physically restrain them at this time, right? So it's more of like, you actually saw the cops, they walked up to him, there was one on one side, there was another, like security guards, I think is what it was. There was another person on the other side, and they're just kind of like welcoming him into their area, but not trying to like hold him and keep him restrained. So that's kind of what the idea is. I have a friend who suffers from complex partial seizures, and his wife basically just makes sure that he's not going to walk off into the road or walk off the balcony. He's tried to do that a couple of times and have a drop down the balcony, down the stairs. And so she just kind of like stands in the places where he might be going that would cause him damage. So it deters him from wanting to go in that direction. Because really, we just want to prevent them from injuring themselves because they don't know what they're walking into. They have no idea what is around them. And so they could be walking out into traffic or into places where they could fall downstairs. And so we just want to make sure that we're preventing themselves from injuring themselves. And then look for things like the medical ID tags or any identifying information to give us a clue on maybe what might be happening with this particular person. Avoid triggering any of the violent behaviors by minimizing the physical contact. So don't physically touch them unless it's absolutely necessary in order to stop them from injuring themselves. But really, you just kind of want to stand in areas, block them by your own body, just standing there to be able to direct them in other areas, but not actual physical contact if you can avoid it. So during the post-ictal phase, we're going to be monitoring the recovery, checking the blood glucose levels, just like we did with the grand mal or generalized seizures, reorienting them to the surroundings. So just like, okay, so here's what happened. This is where you are. How are you feeling? You know, and asking those types of questions. Evaluate them for any injuries that might have occurred during the seizure itself. And then you can, as they start to come more in touch with the world that's around them, we can start getting more in depth of history to figure out, is this something that they've been experiencing? Is it common for them? Is this something that's new? Remember that if this confusion is lasting for over that 20 minutes after the contractions or that mumbling and those signs of the complex partial seizures have abated, make sure that you are calling ALS or rapidly transporting them to the hospital if that confusion is lasting for more than that 20 minutes. Again, question the witnesses, finding out like what exactly happened, what was the person doing, how long did it last for, is there any history of the seizures, and trying to get any kind of a medical history from anyone who's standing around. So that's good protocol to follow regardless of what kind of a seizure somebody is having. So when do you actually need to transport? Because you don't actually have to transport all seizure patients, especially if it's somebody who is epileptic and this is something that happens repeatedly in their life. Giving them a hospital bill is not necessarily what they need in their life right now. There's very few times in our careers where we can be okay without trying to persuade somebody to come into the hospital. And this would be one of those times. The exceptions to that is that if they are pregnant, they should be going to the hospital. If it is a febrile seizure, so that's caused by the increase in temperature, so having an extreme fever, we want to make sure we're bringing them to the hospital as well. And remember, that is more prone in newborns and infants, but it can happen in adults as well. If this is their first seizure, or if it's an unknown cause, like they've had a seizure before, but it was unrelated. I haven't had a seizure in a long time. I don't know why I just had this, or it's my first one ever. That is a good time to go to the hospital as well, so we can start identifying what is it that is causing the seizure, and that we can do that more effectively at the hospital. If the seizures are prolonged and they're extended in their time, so more than 5 minutes, or that status epilepticus in which they have the recurring seizures that are happening and without regaining the consciousness, and so that in total they're not getting blood flow to their brain for more than 5 minutes. And then also we'll add on here, if that confusion period during the post-ictal phase is lasting for more than 20 minutes, those are times we should make sure that we are trying to transport to the hospital itself. If it's something where it's more like that epilepsy, as I said, or they have recurrent seizures and they understand why they have them, it could just be a recovery, making sure that they get enough sugar to replete those glucose stores once they're able to actually chew and swallow again. And then you can ask them, is this something that you want to go to the hospital for? This is just my soapbox that I'm going to stand on for just a moment. I think that we should never deter somebody from going to the hospital if we're thinking they need to go to the hospital. Meaning, we shouldn't really, in my own opinion, we should not be asking patients, would you like to go to the hospital in other circumstances? Right? If somebody was in a car crash, if somebody is, experiencing something like a diabetic episode that they're not, I just don't think the question should be raised unless it's something that they can fully recover from. And then you could ask them, such as in the case with these seizures, that if they suffer from epilepsy and it's a routine thing for them, we could say, hey, would you like to go to the hospital? Or are you feeling good? But in other cases, just be like, I'm suggesting we go to the hospital. So we're going to head to the hospital right now and wait for them to to refuse you instead of giving it to the question. I hope that makes sense. I just think that as medical professionals, we start to ask the question too much of would you like to go? And that gives them the thought of like, oh, maybe they don't think I need to go. And so they start to refuse more readily when it wasn't something they were thinking of doing to begin with. So that's just my 2 cents on it. You can take it for what it's worth. So I do want to show you a video on our right brain versus left brain and how it works as we start to lead into from seizures and into strokes, and just how the two different hemispheres of the brain can work together or not work together when we're suffering from other issues. So Alan Alda is going to be our narrator for this, and I hope you enjoy the video. So it's fascinating just to take a look at how do the two halves of the brain coordinate together, and when we sever that corpus callosum, what can happen in this case of our patient that we saw here. All right, so we're going to move into stroke now and talk briefly about what do we do when we're seeing signs and symptoms of stroke and what are the signs and symptoms of stroke. So first, let's just take a look at what are some of the facts that we have about strokes. It is one of the leading causes of death in the United States. It affects almost 800,000 Americans each year, and about 134,000 deaths each year are caused from it. Between 1996 and 2006, though, it is on the fall. It went from 33.5% of the deaths to compared to 18.4. So we are doing better with our strokes, but it is still one of our leading causes of death. And right now, there's over 6 million stroke survivors that we have within the world. Actually, I think that's US. So it is the leading cause, it's a leading cause of adult disability. And the reality is, it is something that can be prevented. The majority of strokes can be prevented. On average, someone is suffering from a stroke about every 40 seconds within America. And it's because of poor diet and sedentary behavior as we go along. So, just a special thing to note about women and stroke. We often think that breast cancer is the leading cause of death for women, and that's actually not true at all. Cardiovascular disease, including stroke, kills more than twice as many Americans compared to breast cancer. So we think of breast cancer as being a major cause of death, but it's not. It is cardiovascular disease, which includes things like heart disease, high blood pressure, and stroke. More women will die from a stroke than men. The risk is also higher for women because of the higher life expectancy, meaning that they tend to live longer, so they tend to die from things like strokes instead of like from trauma situations or other issues. They also tend to suffer a greater disability after a stroke than men do. So where women are left with the ramifications of stroke for a longer period of time. And women between the ages of 45 and 54 are experiencing a stroke surge, right? And when we look at it, we can say there's like increased risk factors and a lack of prevention knowledge. But something we also need to realize is that this is menopausal age. And what happens is as we start to go through menopause as women, we start to decrease our estrogen levels. And estrogen is cardioprotective for us, for men as well. But it is cardioprotective in that as we start to lose that those levels of estrogen within the system, we actually become more prone to cardiovascular disease. We used to think that men are at higher risk of cardiovascular disease, and that is true for around that age of 50 and below. But as soon as women start going into menopausal ages, we all of a sudden see a change in that, and women actually surpass men in the risk of cardiovascular disease. So that's something important for us to realize, is that it's not just a man's disease, it is definitely a woman's disease as well. So, what are some definitions of what a stroke is? It's basically we get sudden brain damage for a variety of different reasons. It's a lack of blood flow to the brain, and it's caused by, as I said, a couple of different things. It can be caused because of an ischemic stroke. Ischemic stroke is a lack of oxygen because of a lack of blood flow. That's what ischemia means. And it is usually caused by like an embolism or a thrombus. So it's something that is lodging within the area, and it makes it so that you are unable to get blood flow past that area. And this is really the most predominant type of a stroke that we have. It makes up about 87% of all the different strokes. So embolus is when we have something that's just caught. It could be like a calcium deposit, it could be, something like that, some kind of a collection of things within the system that ends up congregating together, creating a clot, and then it lodges as it's moving from our larger blood vessels that we have right here. As it's going into the smaller blood vessels, it can't, the size is too large to make it through these smaller blood vessels. And so it makes it so that you are unable to pass it all the way through there, in which now we get a blockage of blood flow on this area. We can still have blood going to these areas of the brain or other parts of the body, but it's going to be stopped and disrupted from going in this direction where that embolism is. A thrombus is a little bit different in that we have like this buildup of plaque that we have within our system. And what can end up happening with this buildup of plaque is that it's very fragile plaque often. And what ends up happening is it can actually create a blood clot. So a thrombus is when a blood clot is now circulating around. And the same idea that we saw with the embolus, this blood clot can now travel and lodge in these areas as well. But the kind of difference is an embolus or an embolism is something that is like a foreign substance, not a foreign substance, a non-blood related substance like calcium deposits or something like that, that's lodging within it. And thrombosis is when we are dealing with a blood clot that has lodged and broken out. So as I said, that's about 87% of all of our strokes. However, there are some strokes that are caused by hemorrhagic um, bleeds. And so it's a hemorrhagic stroke. And this is actually just bleeding around in the brain or bleeding into the brain. And what we're showing right here is that there's actually damage to the blood vessel itself. So instead of just traveling to the other areas, it's now seeping out because it doesn't have an intact blood vessel to be able to transport that blood from one part of the brain to the other part of the brain, and it's actually just openly bleeding. And that's what a hemorrhagic stroke is. So where can these things happen? We think of it as being, in the brain because we have lack of blood flow going to the brain, and it can. There are blood vessels that are coming here and are feeding the brain itself, but it can also happen on areas that are heading up towards the brain, right? So here we've got our carotid arteries. Here's our aortic arch right here. And then we're breaking over into our subclavian, and we're coming up into where we have our um, carotid arteries that then split into our external and internal carotid arteries. And what you'll see is right here at this, right as it's splitting from the carotid artery going up into the internal carotid artery. The internal carotid artery is the one that goes up and feeds the brain, that we can have the issue occur even within here. So it can be happening like within the neck, so to say, or it could be in any of the arterial structures that we have within the brain itself. So it's just kind of to look at like where could this be coming from? As far as symptoms go, so what happens when we exhibit a stroke? And a lot of you might already recognize a lot of these signs and symptoms that we have, but it can be caused by a sudden and severe, or it can be shown that they're having a stroke by having a sudden and severe headache. It would be their worst headache that they've ever had in their entire lives, and just extreme sudden pain that they're experiencing. The thing is that strokes only will show a headache about 60% of the time. So it's not a conclusive, like if they don't have a headache, they don't have a stroke. But if they do have a headache, it will be the worst headache that they ever have experienced. We can have vision distortion. What am the word I'm trying to talk for? Disturbances. There we go. We can have trouble seeing things, just having like things passing across your eyes, like you have like little floaters, but it's more enhanced of what you're seeing. It could be sudden dizziness, trouble walking, staying upright, confusion, or having a hard time speaking. And sometimes that's really frustrating for the individual. because they're trying to communicate with you and they're speaking, but their words are not making sense. Sometimes they're just unintelligible, and sometimes it's just the wrong words where they're trying to say something to you. And this can actually continue after the stroke has subsided as well into their recovery in that. And they're having trouble speaking to you with words that are comprehensible. So they might be trying to indicate to you, can you open the door? And it's coming out as cat the feed, and they're confused, and you can see that frustration that's starting to form. When that's happening, you can also try having them write things down. Even if they're not able to speak effectively, sometimes their brain can still communicate enough to be able to write something down because it uses different areas of the brain, and maybe the uh, the speaking portion of their brain is affected, but the ability to write is not. However, they can also have sudden weakness, numbness, either in the face or the arm or in the legs. It looks like they just went to the dentist and had a shot of Novocaine, in which they're not able to control or are not able to smile with both sides of their mouth, in which usually you'll just see that on that one side that's affected. But the interesting thing is where the affection comes from is it splits right around your nose level or so. So if you were having vision disturbances, the eye that is having that vision disturbances is usually only appearing in one of the eyes. Or if you're looking at pupils and you have one that's not responding normally, usually that indicates that the stroke is happening on that side of the brain. So if I had my left eye was not responding well, or I was having vision disturbances within that left eye, I would be having that stroke on the left side of my brain, getting a disruption of blood flow. But at the level of the nose and below, everything switches to the other side. So again, if that stroke was happening on the left side of my brain, it's going to be the right side of my mouth that is starting to turn down and not respond to muscle contraction. Looks like I just got shot with Novocaine. My arms will not be strong or weak, or I'll have numbness and tingling on that right side, or same down with the legs. So at the level of the nose, it switches from being at the level at the side of where the stroke is on to the other side of the body. So that's something just to keep track of and to understand. Some different ways we can evaluate somebody or assess somebody to find out if we think they might be having a stroke. One of them is the Cincinnati Stroke Scale, in which we're looking for these three different things: the facial droop, the arm drift, and speech. So, facial droop are both sides of the face moving equally. Or an abnormal response would be that one side of the face does not move at all. So you can literally just ask your patient, hey, can you smile for me? And seeing, do we have symmetric movement on both sides, or is one of the sides affected? Then we can ask them to just raise their arms and hold them out in front of themselves. If both our arms are moving equally, that would be normal, right? So that would be a normal response. An abnormal response would be that as they start to lift both of their arms, one of the arms just doesn't quite come up, and it starts to drift down or away on them, and they're just having a harder time controlling it. It's not symmetrical movements on both sides. Then you can do something with just like asking them to repeat a simple statement, like Mary had a little lamb, in which, are they using the correct words, and is there no slurring that's being present? That would be a normal response. An abnormal response would be that if their speech is slurred, or if they're not using the correct words, or if they're not able to respond at all, that would be an indication of a stroke as well. So you're looking through and assessing these three different things: the facial droop, the arm drift, and the speech, using the Cincinnati Stroke Scale to determine whether somebody is having a stroke or not. The LAPS, the Los Angeles Pre-Hospital Stroke Screen, is another one that's commonly used. Screening criteria, they take a look at a few more details and history of the patient. So things like, how old are they? Are they over the age of 45? More likelihood that it would be a stroke if it was over the age of 45. No prior history of any seizure disorders. So if they're used to having seizures, maybe there's something that's going on with the seizures themselves. So we want to just kind of deter, we're ruling that out, like we talked about ruling out things before. Is this new onset of the neurological symptoms happening within the last 24 hours? So is this something that's new and acute and hasn't been going on for a long period of time? Was the patient ambulatory? Were they able to walk at baseline just right prior to the event? So asking people who are around to find out what happened, how long it's been happening for, what were they like beforehand, what have they been exhibiting signs and symptoms of since that. So if they were ambulatory, walking around, everything was fine, and all of a sudden now they can't, that starts to lead us more towards the, hey, maybe this might be a stroke, something that's set on. And then looking at their blood glucose levels just to find out if there's any issues with blood sugar levels or diabetes that might be going on. So looking at it and making sure they're between somewhere between like 60 and 400. If they're on either side of that, uh, we're thinking that maybe it would be something other than a stroke. It could be something that's dealing with diabetes if we're below 60 or over 400. So we're just kind of like screening these things out and just finding out what are the issues and what best might be caused by. And then again, we're going to ask a couple of questions, like asking them to smile. And is it normal, right? So is it a normal smile equal on both sides, or is there a droop on the right or the left side? And then you can just like check mark on these different things, and asking for grip strength. Ask them to grasp your hands. Like we're checking that circulation, motion, and sensation. We're now doing the motion side of things and asking them to grip. And is it normal on both sides, or do we have a weak grip on one side or the other, or inability to move at all? And then arm weakness, that's going after that drift. So asks them to lift their arms up straight out in front of them and to hold that for a minute or for a little bit, not a full minute, and just seeing what happens. Do we have equal bilateral movement and symmetrical movement, or do we have it that one of the arms is drifting down or falling rapidly, that it can't maintain that strength? And so, and we're really looking for, are things happening bilaterally or unilaterally? Right? So if it's just happening on one side, that is more of an indication that it is stroke. If it's happening on two sides, we're on both sides, we're having something else maybe going on. Typically, we don't have a stroke on both sides of our brain at the exact same time. So we're looking for other issues that might be coming up if it's happening bilaterally. So if it's unilateral, more likely that it's a sign and symptom of a stroke. We can have also what's called transient ischemic attacks, TIAs. These are considered like mini strokes. It's a warning sign. They get the same signs and symptoms of what they see with a stroke, except that it resolves within a couple of minutes or maybe even up to a couple hours, like an hour or two. But it's not something that's longer lasting. So, and it's usually within a couple of minutes. It's more of like they exhibit signs and symptoms of a stroke, and then all of a sudden everything's okay again, and it's not long lasting by any means. So if that happens, it's considered a transient ischemic attack, or a mini stroke is what people call it in kind of layman's terms. And what we need to realize is that really this is a warning sign that a future stroke is on its way, because up to around 40 to 60% of people who exhibit signs and symptoms of a TIA will have a stroke in the future. And actually a lot of times it's up to like that 60%. So we need to be alerting them like, excellent, it looks like you didn't have a stroke right now, right? But we need to get you into the hospital. We need to get you in to see your doctor, because it's a warning sign that a stroke could be coming. And not necessarily like right away, but it could be like a month or two down the road. And so they just need to be looking at things they can do to change their lifestyle in order to make it so that they don't suffer from a full-fledged stroke. So, what are these things that we can do to prevent strokes? Blood pressure is number one. If we can learn to get people's blood pressure under control, hypertension and cardiovascular disease is the leading cause of stroke. It is a type of cardiovascular disease. So, if we can maintain our blood pressure to normal realms through treatment, it could be through medications or it can also be through lifestyles, which we'll talk about in a little bit later within this list. If they are exhibiting atrial fibrillation, in which we have a quivering of the atria of the heart, that can actually start to back up blood flow from moving proficiently through the heart, and it can create clots within the system. And one of those places that those clots can go is up to the brain once they actually make it out of the heart. And so we need to just be watching for atrial fibrillation. They might want to consider blood thinners that can help slicken those platelets so that it's not forming clots as much, to be able to reduce that chance of having a stroke. So that's why a lot of people will go on things like an aspirin a day, or on Coumadin or heparin, different blood thinning medications when they have atrial fibrillation. Also dealing with perhaps in cases where they need a pacemaker, they'll actually get a pacemaker uh, inserted into the body as well. Smoking is a huge risk factor. Sorry, I need water. Smoking is a huge risk factor for stroke. Having tobacco within the body and the disruption that happens because of the disease, the damage that is done to the blood vessels as a result of actually just the smoke itself, um, that can all lead to cardiovascular disease and can lead to strokes. So stopping smoking is one of the best things that you can do to prevent from having strokes. Keeping alcohol consumption only in moderation instead of excessive alcohol consumption is always good for us as well to prevent cardiovascular disease. Controlling our cholesterol levels, right? When we start talking about arterial sclerosis or atherosclerosis, we're dealing with a buildup of plaque, which is ultimately caused because of low density lipoproteins are coagulating underneath the intima, or that lining of the blood vessel underneath the endothelium, and it's starting to oxidize and create a lot of plaque buildup and fatty acid cells and foam cells and such, and those can start to block blood flow from getting into areas because there's literally just a narrowing of the blood vessel itself, and then the risk of the thrombosis occurring because of that, and lodging a blood clot in that process. So we do want to make sure that we're controlling our cholesterol and having, good habits as far as exercise and eating right for that. If they are suffering from diabetes, you are 4 times more likely to suffer from cardiovascular disease, including stroke. So making sure that diabetes is under good management and that they're a functioning diabetic instead of somebody who is suffering from a lot of drawbacks from diabetes. Then doing things like exercising daily, lowering their salt and fat intake, eating healthy, getting vegetables and fruits into their diet. All of these things can help to combat our cardiovascular disease, including stroke. So these are all good measurements to take for both our heart and our brains. The really important thing, and I can't stress this enough with a stroke, is that time is so important. The more time the brain goes without being able to have blood flow or oxygen getting to it, the more damage that is done. So, being aware of strokes and having it as one of our first rule outs whenever we are in a situation where there's cognition issues is really good for us. We want to get them to the hospital as fast as possible when they are exhibiting signs and symptoms of a stroke. So asking really good questions as far as when did this set on, how long has it been going on, what happened, and getting a really good history of it and doing that quickly is important. We have kind of like these time frames that we're dealing with when it comes to the strokes themselves. One of the things that they need to do before they can determine whether certain um, treatments are effective is to do a scan to find out if it's a hemorrhagic stroke or not. So the first thing they need to do is do a scan and find out if there is open bleeding within the brain. They will deal with open bleeding within the brain different ways, such as like going into surgery, compared to if it's because of a thrombosis or an embolism. When we're dealing with a ischemic stroke, which is, again, remember, 87% of the strokes typically are that, and we have confirmed that it is not a hemorrhagic stroke, then there are medications we can give, such as TPA, tissue plasminogen. I think I have it right here on the next slide. Oh, no, I lied. Activator, in which it can actually start to break up clots. But the risk of administering TPA is greater after about 3 hours after the onset of the stroke. So we have this golden time period from when the stroke begins to 3 hours in which we can determine whether we should be administering TPA or other fibrinolytics to break up the clots, right? That's essentially what they need. And so we need to do it. However, we need to make sure that it is not a hemorrhagic stroke first. So we might need to transport them to the hospital as fast as they can possibly get there, knowing what time the stroke symptoms started so we can relay that to the hospital themselves. They'll quickly get them into the scan to be able to find out if it's a hemorrhagic stroke, but that test does take time to be able to do it. Then after they get the conclusion on that they could actually give these medications, they'll only give them if it's within 3 hours of when the stroke first set on. Basically, the risks will outweigh the benefits of it if it's gone for too long of an extended period of time and they won't actually administer those medications. So we need to make sure that we're getting them into that hospital within that 3-hour period so that we can, before that 3-hour period, so that we can get the medications on board within that 3 hours. So time is of essence when it comes to a stroke and getting them there quickly. So the questions is like, well, why aren't they going to the hospital right away when they have strokes? Like, why aren't they calling 911? Because there's a long delay usually between when a stroke sits in and when somebody actually calls 911. So you have all that time, plus any transport time from the ambulance or anything like that, and observation on the scene. Well, why don't they call 911? A lot of it comes down to they don't recognize the symptoms. They don't understand what's happening to them. They just know that something's off within their system. They're in denial that it might be a stroke or something more significant. Heart attacks are the exact same way. Maybe they think there's nothing that can be done. Like strokes, you have a stroke, there's nothing else you can do. So I don't, or maybe they don't know that it's a stroke and they just don't think there's anything that the hospital would be able to do. Sometimes it's that they worry about cost and how much it's going to, impact their budget and whether they can really afford it at all. And so they're hesitant to want to do that until they know it's actually something that needs to be seen at a hospital instead of just going to the doctor. But all of that decision-making process takes time away from us being able to get them within that 3 hours to the hospital. Some of them just think that the symptoms are going to go away, right? They think it's temporary. I have this numbness, this tingling in my hand and in my arm, and it's a little weakness, but I think it's just a nerve issue. I don't think it's necessarily a stroke. And so they think it's just going to go away. And sometimes, people just don't want to go to the hospital. They're afraid of them, they fear them, or they don't trust them. Any of those types of things can be setting into play as well. Treatments. So as I talked about, we have TPA, tissue plasminogen activator, is a fibrinolytic, and there's also clot removing devices that can be used. There's like Mercy retrievers and Penumbra that they'll go in, they'll bust up the clots or they'll scrape them out. Those are all things that we will use to treat when it is an ischemic stroke because there is an actual clot that's happening. If it's a hemorrhagic stroke, they'll go in and they'll either like clip or coil within those blood vessels to be able to stop the blood flow from leaking out into the brain. So what about as far as recovery goes? 10% of stroke survivors recover almost completely. So there is a portion of strokes that is just complete and there's no issues whatsoever with it. 25% will recover with minor impairments with just some issues that they might experience longer term, but it's just minor responses. Beyond that, 40% experience moderate to severe impairments that will require some special care. And then about 10% require care within either a skilled care office or another long-term type of care facility that we have. And so just looking kind of at the prognosis of that. And then about 15% can end up dying shortly after the stroke. So those are kind of our percentages. Most people will recover with either minor impairments or moderate to severe impairments that require special care. Some can require completely, and some actually will end up dying shortly after the stroke. So that's what I have for you as far as strokes go. If you have any questions, you'll be asking in class, and I look forward to that.